let's talk about it.
Hello and welcome back to Thicc Radio, the podcast where we talk about gaining, feedism, and everything in their orbit. I'm James.
And I'm Tim, so let's get into it. Today we're welcoming to the show for the first time a very special guest. Today we are welcoming Dr. Gaynor.
Hello.
Hi, how are you?
I'm well, thank you. Thanks for having me on.
Pleasure to have you. I mean, obviously we're excited. This is something we've talked about for a little while, and I don't know, Tim, you and I were talking about this just before. In the community, it feels like there are sort of three people of professions that every gainer has always been desperate to talk to, right? Like a doctor, a dietitian, and a psychologist, because we're all just desperate to know the tea. But Dr. Gaynor, are you ready to get into it for today?
Yeah, let's do it.
Oh, fabulous. So, first off, how long have you been a doctor for? Well, hang on, I should qualify that. Like, I know that as someone outside of the medical industry, there's like doctorate of music, and there's like doctor of other things. Can we just verify you are a doctor of like the stethoscopic medical kind? What is your technical doctor thing called?
Yes. I'm an MD. I'm a doctor of allopathic medicine.
Fabulous. How long have you been a doctor therefore for?
I finished medical school in 2015 in the States. That's followed by additional training in residency. I've been a general surgeon, boarded and in practice since 2020.
Awesome. Tim, translate? Like, what does that mean?
So after medical school, you have to do training and residency, and you do that in like one hospital though, right? Like whatever hospital takes you on, you do your residency there, and then after you do your residency, you kind of are free to either go to private practice or stay on with the hospital.
With a hospital. So yeah, you can either go to private practice, or you can go in. Most people go either into a group or hospital-owned practice. Yeah.
Awesome.
As far as that medicine specificity, that I'm not familiar with.
So I'm a general surgeon. In terms of medicine, in the States, there's two kinds of medical school. There's doctors of osteopathic medicine, and then there's allopathic medicine, which is the more traditional. You learn all the different.
Oh, gotcha. So like the whole body rather than.
Osteopathic medicine is kind of thinking of the whole body and how each individual part affects the rest.
Oh, okay. I thought osteopaths were bone specialists.
They do a lot with bones, and some of their initial stuff had to do with like adjustments and how adjusting, like I said, kind of adjusting one thing kind of affects everything.
Mm-hmm.
I don't want to upset any DOs that may be listening in. They can come on someday and defend themselves, I guess, though. So
yes, that would be fabulous. DOs listening, reach out to thiccradio@gmail.com. Let's get you on next, girlies. That would be fabulous. And when you talk bones, the only reference point I have is Whitney Houston screaming, "Look at my bones, Diane!" Like that's all I have to offer this deep conversation. Apologies. But that's fabulous, like to know that you've got that kind of oversight. And I was going to ask how long you've been a doctor for. So you said you graduated 2015. You kind of been now without oversight since 2020. So you've been kind of going full hog, ironically, for the last 3 years. And how long do you train as a doctor for?
Medical school in the States is 4 years after 4 years of undergrad. Most people study biology or chemistry, so it's all kind of cumulative. Medical school is 4 years. Usually general surgery is 5 or 6 years, depending on the program. Some people require an additional year for research, or just because life happens and it takes a little bit longer to complete. And then should you pursue fellowship training in something like minimally invasive or bariatric or breast, and there's other fellowships so you can subspecialize. And those can range anywhere from 1 to 3 years.
Wow. So, I mean, realistically, to put a vague stamp on it, you've been a decade and a half kind of working towards working with bodies, learning bodies, doing all of this to the point where you're at now. Is that right?
Yep.
Wow. That is much more of a commitment than I have ever made to truly anything in my life. So that is, first of all, a little round of applause, because
No. I joke with my people, it's like I gave up my youth, but it's fine. I'll make up for it in the 30s. So
Love. So in that case, because you've been doing this for so long, like what inspired you to pursue becoming a doctor in the first place? Like what was the kernel?
I honestly don't know. Growing up, I was kind of the one that always got tagged along with the aunts to translate. My mom's side of the family is Hispanic, and so I spoke Spanish growing up. And so I was kind of drug along to translate at each of those visits. And then we always hosted a lot of family coming up. So anytime anybody was sick, I was always at grandma's house and kind of helped with here, have water, have soup, have whatever, get better. And, in school and things, I enjoyed those were the classes that were hardest, and I kind of gravitated towards them. And anyway, that translated into medicine eventually, and taking care of folks.
Fair enough. Tim, I don't know if I've ever actually asked you this. I mean, I probably have, to be fair. We've done a few episodes and I've known this bitch for a couple of years now, so this has probably come across the table at some point, but like what got you into wanting to become a nurse?
I wish that it was that altruistic, but honestly, I went into nursing school because I thought steady paycheck and better money. Fortunately, I discovered that I actually liked it while I was in school because there's no amount of money in the world that is worth some of the stuff you have to put up with. So if you don't have some love for it, you simply just can't succeed. Like you can't treat nursing as just a business opportunity because it's not. So, and same thing with being a doctor. You can't just look at it as a business opportunity.
No, for sure. I mean, I have a lot of respect for our nurses, and I do this because there was no way that I could do that. I think it takes a stronger person a lot of days.
It's definitely it can be quite a workload.
Yeah.
I mean, it's interesting to hear you both say that because obviously from the outside perspective, I can't help but think of the typically gendered idea there that nursing is the more feminine position and that the doctor is the more male position, that being the doctor is harder and being the nurse is easier. Like that typical gender assigned back and forth. But I mean, to boil it down, what is ultimately the distinction between like nursing and doctoring?
Well, there are many things that I cannot do by law. I can't write an order that has to come from a doctor. Like everything that a nurse does is through doctor's orders. And like, I can't perform surgery, obviously. I can't diagnose anyone with anything. My function is to gather information, assess the patient and what's going on with them, get all of the ducks in a row, and then present that to the MD so that they have enough information for them to make their decision. And then I carry out whatever their decision is.
Okay. And I like that you mentioned ducks in a row because what I heard initially was duxelle, and now I just really want like a nice mushroom sauce. Again,
there's always room for a nice mushroom sauce.
Always, I need to send you my recipe for a miso mushroom sauce. It's fucking banging, girl. It's good. But I like hearing this kind of background about why you wanted to get into it in the first place, right? Because obviously, pivoting now to, I guess, more the specifically gainer side of things, obviously, and we've covered this in previous eps, there is a huge conversation around gaining versus the potential run-ins with doctors versus how we talk to doctors, engage with what a doctor has authority to do and say, and just all of these conversations. With that said, you yourself, Dr. Gaynor, are quite large, I would argue. Have you always been on the larger side?
Yeah, I I've been into this, as many of us are, longer than we care to remember. Was never really able to act on it, but did, through undergrad and then med school and whatnot, have my little binging episodes and whatnot on the side. And anyway, I didn't become an active participant until 2020 and kind of took the cover of COVID to kind of actively gain. But I'd started at probably 240, I think. I think through medical school, I was 230, 240. So I was already a bit heftier.
And what are you now, if you don't mind me asking?
A frustrating 278.
Right. So it's certainly not on the smaller side of things.
Not
and
quite.
Speaking more personally here, like what have been your experiences in a medicalized workspace being in a larger body, do you feel that there's a lot of commentary or side-eye? If it exists at all, like what's that experience like for you?
I think I'm still early enough that a lot of my experience has been while I was in training. And so we always work so hard, specifically with the nursing, especially in the ER, that everybody was kind of just working hard. And at least here in the South, everybody's already a little bit bigger. So nobody really makes a point of pointing anything out. If anybody says anything, it's always, oh, have you lost weight? Which is exactly what every gainer hopes to hear from anyone.
I know, right? I hate that.
Oh my gosh, all the time. Sometimes after you've like managed to put on a few pounds, even, and I'm like, is this a Southern thing? Are you like, are you just calling me out or what's going on? But no, I mean, nobody's really called me out. And then after the fact, and this isn't, me trying to like blow my own horn or anything, but I mean, Tim, you can kind of speak to the dynamic between specifically surgeons and, staff in the hospital. Nobody really calls. I mean, if they call us out for anything, it's for being an asshole in the middle of the night or in the middle of the day.
That's really, we don't give a shit what you look like or even what your name is. But if
Just
if you're making our shift difficult, then yeah, we have a problem.
I don't know. I wondered, like, because again, like, I don't fucking know how this shit works. Like, is there like the cafeteria, like high school, where like the doctors, because they're like the, I guess, better paid, cool kids, like sit on a table, and there's like the geeks and the job. Like, I don't know.
When I was at the hospital, I didn't see a lot of doctors in the cafeteria. It was mostly like nursing staff and STNAs and like janitorial work. Like you really didn't see many doctors. Like you'd see them come in to get food occasionally, but they didn't eat in the cafeteria. At least not at the hospital I was at.
Our jobs are a little bit weird. And even like as a surgeon, my job's very different from an internist, say, who is paid to take an entire shift at the hospital. My job is very, specific. I get called about a specific patient or number of patients, and I see those patients and then I leave. At my hospital, I argue that I'm at a community hospital, which is similar to what most people have. And so I come in, I see my consults, and then I leave and either go back to my clinic or go back to surgery, or I just go home because my work is those patients. And so once I've taken care of them and given orders, Tim has to do everything. I just get to provide direction.
And nothing will piss a nurse off faster than if we can't read your handwriting. We'll be like, what the fuck is he trying to say?
Yeah. Fortunately, many people have come before me to pave the way for bad handwriting, but I do my best.
I love it. Representation for bad handwriting. I feel like I would be a great doctor just based on that alone. I could probably write a very successful script just by sort of crayoning my situation through.
There you go.
I was told once I don't have a style of handwriting. I have a style of griffonage. Griffonage is apparently a form of handwriting that is so poor it looks like a griffin's talon just sort of raked across the parchment or the stone tablet and went, there you go, there's your fucking...
The Mark of Zorro, I'm out.
Thank you. Very Legend of Zelda, very The People of Zonai, very... all that fuckery. That is what I'm capable of. I am a long-lost Atlantean, apparently, just translating some subscript from cuneiform. Who the fuck knows? But that's the vibe. Okay, so like you're based at a clinic, you go to hospitals wherein you need patients, but like when you're at the clinic, let's say you're a larger guy, do you have a situation where there's like a cafeteria there where you can have lunch? Do you bring lunch from home? Is it food trucks? I know America can be very different in different places. What is your setup?
I process stress a little differently. I'm very jealous of all the people that say that they're stress eaters. I'm not a stress eater. I'm like a stress faster.
Yes.
I prefer, especially when it comes to like patient care stuff, I prefer to get up and take care of business, and then I'll eat whenever all the work is done.
I'm the same way, and like because I've done a lot of work in LTACs and skill units, like you're given like 25 people. And you have so much to do in a shift, and you're like, well, if I stop now, I'm going to end up being behind, and that's how I could end up going 8 hours without eating, just because I had this huge workload. I'm like, who's got time to eat?
Especially during training, you have, 5 or 6 days of, 16 plus hour days back to back, and you don't know what your day is going to look like until you get there. Because you may be sent to cases all day and you're on the operating room, literally running back and forth, trying to sign patients in and do exams and see consults. And everything else. And, the idea of getting a meal in is not going to happen. And specifically, and hope it's not too TMI or anything, but I have a very sensitive stomach. So I don't want my breakfast to literally ruin my day.
Yeah. I think we need to get to a point on this podcast where we need to encourage more of these types of conversations, because I don't think it should be TMI. I think there are no gainers out here talking about, like, sometimes the food done fuck up your bowel movements, sometimes stress, and sometimes work, and sometimes things fucking gets you in the guts, and it's messy.
Or the quality of food that could be served in some of those cafeterias, because it's not 5-star Michelin stuff,
Yeah. Even now that it's, some hospitals, you're fortunate enough to have access to a physician's lounge or something like that. Like, the food's still coming from the same place. It's not, at least at my hospital, it's not being brought in.
Yeah.
Goddamn. I mean, again, I think this is just really interesting to kind of probe, like, the kind of, I don't know, maybe like the behind the scenes action of, like, the doctor's experience. Like, is there an aspect to your kind of like day-to-day life as a doctor that people might be interested to know about? Like, people might be surprised, or it might challenge some preconceived notions?
I don't know. I kind of feel like I've been in it so long and all of my friends are doctors, so I'm not really sure what's interesting from an outside perspective.
Yeah, people outside the profession really don't want you to talk shop, especially about the gross things.
Yeah. Eyes glaze over, conversation topics get immediately switched, so we just leave it
Which
alone.
interests me. When I worked in scheduling, the nurses always used to love to gather around and tell you, like, the sick stories about, like, I remember this one old fella, he had, like, that chair lift, and his foot got stuck and, like, it ripped out one of his toes, and, like, it was bad, and he had to have, like, a bolt put in, like, from fucking Bunnings, from, like, the hardware store, and it's just hanging off his foot like a fake toe. But they were like, yeah, and, like, really fascinated and, like, looking at the photos of the gory situation, and I'm like,
because you get desensitized to it.
yeah. Also, like, is it a common trait that nurses and doctors like to pop pimples? Because I've heard this.
I don't know what the fascination is with that.
I don't think that's even a medical person specific thing. I think that's just a person specific thing.
Yeah.
Maybe
because I can look at a really gnarly wound, or I can look at, like, a fresh surgical scar and all that, and it doesn't bother me. But, like, the idea of popping someone else's zits is just disgusting. I'm like,
yeah, I mean, I am the specialty that gets called when they get too bad and somebody needs to do something, especially while they're inpatient, and that's never a fun thing. And I'll admit there have been times where I'm just like, put a warm compress on it, it'll evacuate itself. So sorry, Tim.
yeah, because you know who has to apply the warm compress? Me. Standing there for 15 minutes, listen to them yammer on about nothing.
Oh, goodness.
Love that. So basically, sometimes doctors are just the equivalent of, like, your little mum who's like, put a bit of Vicks Vapor Rub on it. She'll be right. Put a bit of iodine on it. Oh, no, it's fine.
Yeah, people will come in and complain about things that you have no power to do anything about. So, that we'll come to the doctor and be like, we know that you can't do anything, but will you please write something to, make this person happy?
I mean, especially by the time I get called, because I don't get called from the ER usually. The patient's already been admitted. So now, like, a whole production has been put together. Like, a huge scene has been made in an ER somewhere. The patient has come to the point where they were willing to sit in an ER for Lord knows how many hours before they were finally seen by a physician for indeterminate number of seconds before a decision was made, and tests were run, and now the patient's been admitted to the hospital, and you get called 24 hours later with the wrong antibiotics, since everybody wants an answer. And I'm like, well, the answer was to have gone home yesterday. This is like a non-issue. What are you doing?
Hello, why are you here?
I know, but now everybody wants the show to go on, so you do your thing. And
Which, that's very funny. Like, when I think of that one episode of Ab Fab where Eddie's, like, desperate for a bit of attention after Patsy's had the affair, and she's like, oh no, I've stubbed my toe, I don't know what's going on, oh, I've got to go, hospital. She calls the ambulance to have her taken. Patsy rides with her, so the pap had taken photos. Then when they finally get there, it turns out it's like an acupuncture needle that's worked its way down from her head all the way to a pinky.
But I've only ever had cranial acupuncture. How many other organs did it harpoon on its way down?
Talking a little bit, I guess, about that misunderstanding, I think this would be a great opportunity to segue into a little bit of medical fat phobia, because obviously this is something we've talked about on the pod, and this is something that, especially within fat liberation, a lot of people talk about. The experience of healthism and sizeism and medical fat phobia that fat people encounter when they go to the doctor. The meme of, I have a sore ear. Yeah, it's because you're fat. Like, that kind of thing. So to touch a little bit on that, from your experience when you've been a patient, Dr. Gaynor, what have your experiences been like in terms of the medical and your size?
I mean, I'm fortunate not to have been a patient very often. Doctors and nurses, I don't feel like we make very good patients. We don't go unless we absolutely have to. I tease my boyfriend that now that we're together, I now have to live forever. And so I went and got a checkup, and I was like, well, I guess now I have to take better care of myself. So went and got lab work and everything else done. And I kind of knew what to expect. And so I wasn't surprised when they came back with, certain recommendations, looking at, your liver labs and looking at, I guess, I don't know, early stuff that I would expect to see in somebody my size before, moving on, which I wouldn't expect to see in somebody smaller, which I now understand a little bit better that it can happen at any size. So things that I would look out for, I mean, obviously everybody's worried about the sugars, everybody's worried about diabetes, everybody's worried about blood pressure and things. Blood pressure then leads to kidneys and then, but it's all kind of cumulative. So in the community, I see people like kind of always bashing the medical community, and they don't like going to doctors because they go in with one problem and immediately just gets blamed on them being fat. Like you were talking about, like foot ulcers or foot sores and things. Like, I think sometimes maybe we go in and that's all we hear, but what us from the medical perspective are trying to say is like, no, but your blood sugar is causing this, is causing this, is causing this.
Yeah.
Sometimes in sparing you the explanation, which sometimes takes a degree to fully comprehend and experience, we're just kind of boiling it down to, well, you're fat and therefore you have diabetes, and so you have this problem. I don't think that that's communicated well on our end, and certainly not heard well.
Yeah, I think there's such an interesting question, because I think even the little chats that you and I've had, Doctor, there's so many presumptions I would make as a non-medical expert about, like, but you're the doctor, like, surely you have an encyclopedic knowledge of all things. If you're meant to be so smart, if you've done 20,000 years in school before being a doctor, why is it all being boiled down to this? And I think there's just a real strong misunderstanding, which I don't think anyone ever really tries to bridge the gap on. We just kind of accept that it's there and just go, well, I guess we'll never know. Though I do want to ask you just quickly, when you meet with patients and next of kin and things like that, do you ever get the kind of side eye from them? Maybe the Joe Blow thinking, Jesus, the doctor's a fat ass. I don't know what he must know about X, Y, Z. Have you experienced that at all?
That's never really come up in a lot of the stuff that I do. When you're working in the hospital, a lot of it is acute care. Now, when I was in training, we did a lot of work with patients where it was more elective. So patients that come in for hernia repairs or gallbladder problems, or, I spent a lot of time working very closely with bariatric surgeons for several years and doing those procedures. And so I meet those patients, and I mean, obviously not every, like or I think I've heard y'all say before, and how other of us talk in the community, not every fat person is a gainer or, into the fetism community or whatever. So, you can't just immediately put them in that box either. I've always kind of come to them from the perspective of, if you're coming to me, it's usually because there's a problem, and it's not just that you don't like the way that you look, because that's treated in a different office. And so usually I try to meet those patients on their terms, like, what's the problem? And usually it's a mobility issue, or they're having just so much pain because of the weight that they're carrying, and it kind of comes from a different perspective. The people are genuinely unhappy, not because of the weight necessarily, but because the weight is limiting in their lives.
Gotcha. And I think that's a really interesting point to focus on, because I think you said that you've worked with bariatric surgery before. Is that right?
Mm-hmm.
Wow. I mean, tell us again, fat doctor, bariatrics, my understanding is that bariatric surgery is like, it's the part where they cut out part of your stomach and they pump out all the fat with a vacuum cleaner, basically, right?
Well, there are a few different procedures that we do in bariatrics. The two that I'm most familiar with is the sleeve. Well, I know about the band. Everybody talked about the band, where you basically put saline in and it kind of restricts how much food can flow through. So you get a little nauseous, you feel fuller faster. It kind of restricts how much you're taking in, but the band has issues. And so most of, at least the community that I'm in, has kind of moved away from the band. And so the two major procedures that I see done are called a sleeve gastrectomy, where part of the stomach is taken out. And then there's a gastric bypass where most of the stomach is taken out and the intestines are sort of rerouted. So less surface area within the intestine sees food, so less of it can take up nutrients, so less is absorbed.
Right. Because it's actually like the stomach isn't the part that like
The stomach is kind of where everything goes
it
before
gets
it's
broken
digested.
down. Yeah.
Yeah,
Like
the
gets melted
acids break
down.
it down, and then
Yeah.
through
The
the small
flow.
intestines do the actual digesting
Yeah.
and
It's the
absorbing
tube that actually
nutrients.
absorbs it.
Yeah.
And the size of it and how much it stretches is what causes all of us frustration when we can't put more in.
Yeah.
Or whatever.
Yeah. Because you have a capacity. You know, your stomach
Yeah.
will just vomit if there's too much in there. It'll be like, nope, I
Yes.
can't handle this.
Yeah, sometimes when people are like, I've had 15,000 calories today, there is a part of me that's just like, I don't know how you do that. Like, where is there room?
Well, if
You're
you can
shoving
space it
into your
out far enough,
toes?
like I think it can make sense if you space it out far enough. Like, because if you eat
Or,
like a large portion, you wait a couple of hours, you eat a small portion, and then like I think if you break it up, it is possible. It's just like some people like me, if I consumed 5,000 calories, I'd be like, I couldn't look at food for a while. I'd be like, no, because my
Yeah.
body's telling me you're done. You're fucking done.
yeah, gotcha.
Well,
That's
and from working shift work for so long, I don't snack. I'm more of binge eat at the end of work or,
Yeah.
A couple large meals a day. And so if you're going to shove it all into one or two big meals, it's really hard to get into, those numbers of calories.
Yeah.
that makes sense. And
Especially if you can't do supplements or shakes or whatever, for whatever reason. So
I think it is really interesting to talk about the genuine limitations, like the physical limitations within gaming, because sometimes we really do reduce it down to just, oh, you're not trying hard enough, you're not eating enough, you're not eating the right food. But like, sometimes there is just real fucking hard walls that you cannot climb, and that's kind of the end of the story. Do you feel that there is an element, and not necessarily you or your practice or even the field that you work in, but medicine in general, do you feel like there is an element to which medical professionals maybe are a little bit unnecessarily fat phobic?
I don't necessarily think that people that go into medicine are inherently more fat phobic than anyone else is. I think fat phobia is kind of ubiquitous to our society for lots of reasons. I think when you compound on top of that, what we know about the effects and the long-term effects of bearing that weight in a community that for the most part isn't interested in, gaining for the sake of gaining and for the appearance of it all, then I think it kind of does compound that fat phobia to an extent. I think there's lots of very fit physicians who they were going to be very fit, whether they were physicians or not. That's the product of whatever societal elements, kind of formed them.
Mhm.
Tim, what do you think?
Yeah, I feel like I've seen as many skinny doctors as I've seen fat doctors. I've seen as many skinny nurses as I've seen fat. Like it's just a mixed bag of body types, and yeah, how can I word this? Like you become there's like this type of fat phobia that is instilled in you during the course of your education and your training because you're told to educate your overweight patients about their problem, like when I was in school, they said like one of the most primary things that a nurse does besides care is education. So like you should always be educating somebody. If you're in a room with like a diabetic person, you can suggest exercise regimens or dietary changes and all this stuff. Like you were never just allowed to let somebody be who they are. You were always trying to like improve on them some way. And so, yeah, I do think it's something that builds as your career does.
Right. And I don't know, I feel like that makes a bit more sense because I think it's really interesting to learn the ways in which fat phobia is therefore taught. Like, as you say, Tim, it's not necessarily that there's like, so specifically, fat people are bad, disgusting, you must tell them. But it's that medical approach of, well, this is what we understand medically, this is therefore what we're going to tell you, this is how we believe you should communicate that, right? So I think there is an element to which all of us should be aware that that's where people are coming from. Understandably, things can be uncomfortable or things can be difficult. But I also think as gainers, we do have a responsibility because what we are doing to ourselves is intentional. I do think we have a responsibility to ourselves to be more willing to step into the ring in that regard to have those conversations and to kind of broach those topics, because understandably, people who are outside of that don't have that motivation necessarily to assert their size and shape. You know, I think that's where a big part of that narrative therefore comes from. Whereas for us, we have an opportunity to kind of have a bit more ownership, maybe, than what other plus size people do. So I think that's something worth being aware of. And, you know, again, Dr. Gaynor, really appreciate you taking the time to kind of share with us your experiences and just kind of talking through all this, you know. So as a non-doctor, again, I think the sort of societal expectation, or at least what gets built up to someone like myself, is you have a weird thing happening, and it's weird because it doesn't normally happen, and so you go, oh, I guess that's a medical thing. Let me go to the medical people. And so the expectation is, I will see a doctor, because he will know all of the exactly 10,000 possible things that it could be, and he will personally triage which one it is, and he will set up a whatever needs happening to basically help me get over it as quickly as possible. Right? Like, that's the kind of generic approach, understanding to health.
I mean, because y'all have listeners outside of the States, I don't know exactly how the medical systems work elsewhere. From my perspective in the US, you shouldn't think of the physician as like the all-encompassing dictionary. You should think of us more of like a set of encyclopedias. So I am S, and you're going to need to look up your thyroid problem in T, but my book has the index for the whole set. So I kind of know that your problem is over here in the next book, and that's some of the disciplines are a little bit more encompassing, and so they're more of an index or an atlas, so they kind of have the bigger picture of everything and can kind of direct better. And when things kind of go off the rails or off the map, then you need to get a little bit more specific, and so that's what we as specialists can provide, that insight, if that makes any sense. Or it's maybe
No, it does.
Yeah.
Like,
it's like you wouldn't go to a oncologist if you have an ear, nose, and throat problem. You know, like,
yes,
any other relevancy to a relevancy that is not applicable. It makes perfect sense. You know, you kind of go where you need to go. And I know that in America, Tim, you've expressed this before, people tend to have just like the one doctor, and you tend to have them for like...
It's just easier that way. It is, because not all hospitals, and like so say like here in Cleveland, the Cleveland Clinic dominates a lot of the medical landscape, but the other big one is university hospitals. Yeah. These two places will not disseminate information to one another. If the patient doesn't come in with their entire medical history from one institution to the next, you're kind of starting all over again.
And usually the hospitals make it very difficult to obtain or transmit that information to another system.
Which is really interesting to me, because within the Commonwealth, at least, and they are different medical systems. Here in the UK, it's the NHS. In Australia, it's Medicare. But they both function similarly, which is that it's universal healthcare. You have a number that IDs you. You basically, the moment you're born, you're assigned a number because you're already there in the hospital being born. So it's very easy to like get that set up. And just anything medically that happens to you, it gets registered against your number. So it doesn't matter where you go. Like because I live in London, if I went on holiday up in Glasgow and, God forbid, hit by a car, leg gone at the knee, several fingers crushed, other issues, blah, 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 they kind of like wheel my lump to the hospital. And they're basically, if they can get basic ID out of me, you know, name, current address preferable, date of birth, the usual bits and pieces, or if I can provide them with my NHS number, they can pretty much load on the system and go, right, this is all the information on this person, because it's all one system.
And this is one of the benefits of universal healthcare that people never talk about, because like people over here in the United States, everyone's terrified of this idea of universal healthcare. But if we had it, you could go to any institution, any hospital, and they could pull it because it would be part of a national database. They would always have your relevant medical information.
Can I ask, as a non-American, when people say they are afraid of the concept of a universal healthcare, what issues are they in?
Wait time. That's what people always will say. That's the very first thing people will say. Well, then you'd have to wait months and months and months, and you know, you could have something terribly wrong with you, and by the time they finally get around to you, you could be dead. I'm like, that happens anyway. That happens anyway. The wait
I mean,
times are
the fact of the
just
matter,
as bad.
yeah, or even if they find out that they have a problem, they just, if it had been seen by a GP or somebody that somebody actually had access to, instead of having to wait to get into the system before finally making the referral, like the delays are there. They're always going to be there.
Mm.
You could wait just as long to have
They'll
surgery here in
even
the
now.
US as you could over in the UK. It could take just as long, and then
Well,
because of the way insurance works here, that's if you even go to begin with. Most people don't even find out something's wrong with them until they're taken to the ER.
yeah.
Yeah, like in my whole life, there has always been this notion of like part of what you do as a responsible adult is check in with your GP at least once a year to kind of do your bits and pieces, give them a blood sample, a piss sample, let them do some, like the usual assortment of treats just to figure out if there's anything going on, because that's how you make sure that if there's anything lurking in the background that you find out about it, so it is interesting to hear that well, I mean, I think we see in the news a lot, those of us outside of America are very well aware that what happens in America is not maybe what happens in other parts of the world. But I actually want to ask, Dr. Gaynor, from your perspective, as you say, you're kind of just doing your job when you have to be the general physician to give a bit of information to a patient, letting them know what's up. When patients are experiencing, and let's use the specific example of fat phobia, when a patient is experiencing some kind of uncertainty or emotional discomfort because of what they're perceiving to be fat phobia, from your end of things, how can they best have a conversation with you to seek a more positive resolution to that?
I don't know. That one's tricky because I mean, obviously, I have the unique perspective of being a gainer and being large, and being in the medical community. And so when I seek care, it's from a very different perspective from, I guess, the average. I was going to say the average bear, but I hate puns. I think we talked about ownership, and I think that's important. And part of that ownership is going to be taking it upon yourself to learn a little bit about some of these conditions. It may be that you go to your initial visit with your GP and they diagnose you with a few things and make some recommendations. And it may be that you can't act on that now, and you tell them that you want to take some time to learn about this and come back and have a more informed discussion. That's an opportunity that we have here in the States, and sometimes it's harder to get in, but it's usually easier to get in for a follow-up appointment. And most of the chronic conditions that you're diagnosed at these visits are still going to be a problem in 6 months. So, so I went to the physician 2 months ago, and typical now in the States, for whatever reason, I didn't get to see the physician. I saw the nurse practitioner.
Yeah, that's always a given.
Incidentally, I had trained, who incidentally was a tech when I was in the ICU, and I helped her, wash patients and stuff. And so now she's my nurse practitioner who's been out for 2 months, and now she's kind of giving me the third degree about medications and whatnot. So my lab work came back, and I have kind of early signs of hepatic steatosis, which is like a fatty liver, which of course, and then kind of borderline blood sugar, which again, of course, and then I had concerns about sleep apnea because once you get to a certain size, it comes for us all. And so I wanted to get a few things evaluated, but I have a sensitive stomach. And so one of the medications that they like to prescribe, especially for earlier pre-diabetics, is metformin. One of the major side effects of metformin is GI upset. And so I asked about alternatives. Well, one of the alternatives right now in the States that's very popular is Wegovy, which is an infamous weight loss drug. And everybody's using it for weight loss. And I kind of jokingly mentioned, I was like, well, I don't really care so much about the weight, but whatever you think we need to do about the sugar, I don't like the sound of metformin. Is there another option? Because there is Actose and some other, there's other blood sugar lowering medications
Glipizide
available.
is another popular
There's oral
one.
forms of things. Yeah, there's lots of options. She said, well, if the metformin doesn't work and the Wegovy's too expensive, then I guess that's all we got, which is an inappropriate response. But I know that nurse practitioner, I knew her background, I knew that she was new. And so I had that insight, whereas the average patient is going to go in and they're not going to know what to do. I don't know. I don't think that it's her fault for not having the experience. I think it is what medicine is kind of right now. And I don't think that my experience was unique, even if my perspective was, same thing with anything with blood pressure. If she was worried about the blood pressure as related to, gaining and
I was just going to say that I always encourage second opinions and third opinions if you have to. And yeah, it can be a pain in the ass to get that second opinion because you have to go through the whole process of the doctor taking you on, and you have to, fill out all those paper forms about your history and all that stuff. Like, you're going to have to do that several times to get several opinions. But I do think it helps because, like Dr. Gaynor was saying, sometimes people are new and they don't have the necessary experience to realize that there are other options available, and some doctors are even motivated towards specific things because that's just what they prefer, or maybe they have a kickback with the pharmaceutical company. I honestly don't know, but I always encourage multiple points of view on these things. And if you go and you get 2 or 3 opinions and they're all saying the same thing, odds are it's right.
Just that physicians and healthcare practitioners are also human, and we're also going to have bad days. And you may catch us on the day where we had 30 patients, and I honestly just didn't have time to sit and draw you the pictures of how this is all connected. And I just need you to know that you have these problems, and this is my plan to fix them, and hope that you just kind of take that on faith. And if you show up at the wrong point in that day, then you're not going to hear that well, and I'm not going to be in a position to communicate it well.
Yeah. I think it is really good to hear this, honestly, because I think what I'm taking away from the pair of you here, and just like you just said, it's doctors are human, people make mistakes, people have days where their energies are up and down. And while obviously none of us want that moment where we have a medical person in front of us not having a good time or being short with us or however it works, like there is an emotional moment of being like, oh, I guess this is what's happening in front of me. I have to choose to kind of walk with that or not. And as Tim says, that's where second and third opinion comes in. A person could turn around and say, do you know what? I saw my regular physician. I don't know if they were maybe having a bad day or maybe being a bit short with me, but I'm not sure that I quite understood that this was the answer that we were going for. I don't know that I necessarily agree. Maybe it didn't come off right. Could we just do a second test just to make sure, or maybe just as a second opinion? Like, I think that's totally valid, right? And I think it also takes some pressure off of doctors because, again, from the perspective of a non-medical person, we're kind of geared to just assume that you know what's up, and therefore, how could you get it wrong? How could you, not treat us as perfect, whatever? You know what I mean? So I think it's good to have that conversation, bringing it back to doctors are people are people, and if people can sometimes not be in good spaces, or can sometimes make mistakes, or sometimes just not be feeling great. So there you are for the listeners. Be aware that your doctor's a person, and that person may be feeling feelings. So yeah, bury that. But in terms of maybe things like, I guess maybe more specific things, you'd mentioned that Wegovy and metformin sometimes have things with GI tract and weight related things. Could you maybe provide some examples of, like, for gainers who might be going to doctors and know that they are maybe going to need medication for certain things? Can you maybe recommend some names of brands, perhaps, or things that gainers could put into the conversation where it's like, if you had XYZ, I'd be more than happy to do a course of this, if that be the, because I don't even know, like, are you even allowed to suggest?
Yeah, I'm afraid that's a little bit outside of my wheelhouse. I think physicians are more open to their patients knowing names of medications and being asked about medications, because in the States, very differently from other countries, like literally the TV is constantly telling you to ask your physician about whatever drug, and it's on Instagram and it's on all of your social networks and everything. It's ask them about Wegovy, ask them about this drug, ask about Abilify, ask about, whatever medication under the sun you think. And, patients come in, they're asking about these medications sometimes, or they ask about, in my world, they ask about meshes. Like, oh, well, I heard that mesh was bad. And I was like, I have to read all of the books and know all the things, and I have to watch your TV. Like, I don't know what you're talking about. Like,
well, and it's so funny to me because, like, if one side effect is reported in a clinical trial, they have to put it in the disclaimer, of the list of side effects. And, so it could be something wild and crazy that it happened to one person, but now it's listed as a side effect. And now people are asking, well, I don't want that to happen to me. And I'm like, well, there's no guarantee it will, but there's no guarantee it won't, we just don't know.
Well, and by the same measure, it's in the pharmaceutical companies kind of bury the more common side effects, which people also don't want in the long list of side effects,
Yep.
hoping that people just think like, oh, well, those will never happen. And I was like,
Mhm.
well, most of them won't, but that one that you really don't want happens all the time.
So, Dr. Gaynor, I really wanted to pick your brain about a particular medication that you mentioned like is growing in popularity, like it's sweeping the nation in popularity for weight loss. The most common one that I've seen is Ozempic. Everyone's talking about,
Yeah.
oh, I want to get on Ozempic because I want to lose 5 pounds. I want to get on Ozempic because, and they're treating it almost cosmetically at this point, and I am really uncomfortable with this. It really makes me uncomfortable because like I remember being told like in pharmaceutical class that like if you don't actually have the problem and you're taking the medication, you can give yourself the problem.
Yeah, and certain medications will work that way. Insulin is used sometimes. Well, my understanding is that insulin is sometimes used even in like the bodybuilder community because it is a steroid. It will cause the body to use different metabolites differently and to store fat and proteins and things. So especially like during bulk phases and stuff, it can really help to, speed that up. But over long term, it can also desensitize the cells in your body to normal levels of insulin. So you come off of it and all of a sudden your cells, and so that can kind of put you into like a type 2 diabetes situation,
Yes.
where the body's no longer sensitive to insulin specifically. Some stuff like Ozempic, and I'm just being honest with you, I'm kind of looking it up a little bit now because I don't prescribe these medications. If you can't cut it out, I don't really have a lot of interaction with it.
But again, I think even you saying that is totally fair because it's like you're a physician, you deal with shit every single day, and Ozempic sweeping the nation, you're not fully abreast of it. You're not being handed like the up-to-date articles on everything that it does, and people are probably going to their doctors, begging them, willing them, please, please, give me the miracle, give me the miracle. And a doctor might just go, well, listen, if I have no other information to give, so if everyone else is saying do it, and this is
Sure.
what all the clinicals are saying, then sure, go have it.
Yeah, and some doctors will do that, and others, hopefully, like Dr. Gaynor
Yeah.
will be like, well, I don't really know that much about it, so I don't feel comfortable prescribing it because I don't know how this is going to affect you in the long term. But you will run into unscrupulous doctors. They'll be like, yeah, whatever, and they'll just write the script because either they're trying to get you out faster or they don't care.
There's an example we could probably bring up here. A YouTuber that both Tim and I watch. She shared her experience about being on Ozempic in the past. I think it was only, what, 6 months? Since
Yeah,
she was on it?
and it was not a pleasant story.
The things I took away from the story really were the ways that she described her interactions with her doctor, because none of them were actually bad, right? But essentially what it came down to was this is a person who has like some kind of bad variation of IBS that could, affect her blood levels at some stage. That was something she really struggled with for a long time. And a lot of the language was just, well, it may not be working yet, but let's see, and we'll try this then. We'll up dosage from part milligram to a full milligram, and this, that, the other. And it's the kind of thing that I took notice of because I was like, the way that she kind of tells the story is that I don't know if she's giving full information to the doctor or if the doctor, maybe much in your situation, didn't necessarily know everything about it. But it just seems to me like she suffered and struggled for 6 months. And I don't think it's the doctor's fault, but I think it really does paint a picture of the nature of the fat phobia that must exist within medicalized spaces, wherein maybe part of the reason why people weren't that phased when they could have noticed things is because they were thinking, well, if you're fat, we're willing to try this, and I think that comes back to a lot of examples that people reference. Reddit is flooded with memes of, it turns out I had like stage 3 cancer. That's why they were like, oh, but you're fat. This isn't a problem. And then I went on chemo and started losing weight. And then everyone was like, oh my God, you're losing weight. Like, that's great. You look so great. And people are like, I'm literally rotting from the inside, dying of cancer. Please, please stop this. This is horrible. Which I don't think applies to you at all, or the conversation.
No, but I mean,
So
we hear within the community of patients that come in with, back pain, or they came in with, some other kind of ill-defined problem, and they were large, and so it was blamed on that, and it turned out to be some metastatic cancer that was missed. And I specifically work now in breast oncology, and I have patients who weren't diagnosed with tumors until they had some other medical condition that caused them to lose a catastrophic amount of weight. And all of a sudden, this huge mass is like in the breast where they didn't notice it before because
It was just
nobody's
covered with
looking.
fat, so
Nobody cared. Yeah. Well, not that nobody cared, but nobody's looking for it. So it didn't present itself as a problem until it was a problem.
yeah.
So
I want to ask, from your end of things, and again, I asked something similar before about like what people can say to you to have maybe more of an amicable conversation, but to listeners who, maybe want to be more conscious of having medically informed conversations or having a better relationship with their doctor, what are some just pointers that you could give to listeners about things that they could be aware of, or things that they could say or maybe not say, or particular list of things?
Again, I have a very unique perspective in all of this, but I think people should also know that people tell us a lot weirder things than I'm kind of okay with being fat right now, or this is something that me and my partner are okay with, or that's not something that I want to focus on right now, to kind of change the perspective a little bit. Or, I'm not in a place right now in life where losing weight is an option. Can we focus on, whatever problem they brought up and blamed on the weight?
That's another thing, like, because I often think about this, like, how would I want to say something to a doctor? And I feel like something I would probably say is, like, regardless of what the thing is, but if they make inferences about my weight and size, I probably would make a point of saying, I just want to be honest here, I'm on a bit of a body journey. I'm feeling actually really comfortable in myself at the moment. Is there a way that we can maybe preference some options or medications that maybe don't have weight loss as an intention or as a side effect? Like, would you say that that's maybe a way to kind of angle?
Yeah, I think, so a lot of people in our community specifically have dealt with like eating disorders and other things. That's another thing that if you bring that up in my office, like, well, we're not going to talk about weight loss at this visit because that's, I'm losing you, and whatever, investment you're putting into any of my kind of recommendations to, if I start talking to you about losing weight, well, then I'm just another fat phobic, person that's going to push you back into your, self-worth and self-esteem and, everything else.
That's another episode we need to have at some stage. I don't know. Well, we can talk about that later. But it's another episode we need to have at some stage, like talking about eating disorders and disordered eating, which sisters, like, they live in the same neighborhood, but they're not the same street, right? Like, they often have overlap, but wildly different visuals. And once again, when you're looking at fat people, people don't notice. They're like, what do you mean the fatty has, like, anorexia, bulimia? That can't be possible. Like, so we'll have to do that episode another time. I think that could be its own thing for sure. But I want to take this opportunity to ask you, you are a medical professional here on our show today, and again, thank you for giving us your time to share your experiences and whatnot. Being a gainer yourself, is there anything to the gaining experience and the medical experience that we haven't touched on today that you think is worth bringing up before we wrap things up?
I don't know. I would say there's not a lot that I have learned that has proved to be particularly beneficial towards gaining. There's certainly been things that I've learned, in medicine to, look out for early signs of stuff, because preventing it from kind of sliding too far can prevent a lot of the other downstream problems that we see in some of our folks that are, particularly larger, now dealing with significant like health concerns. And I realize that there's a section of our community that doesn't care so much and kind of gets off to kind of the health related issues that crop up, and more power to them. I'm kind of here for, the long time, not the fun time aspect, I guess. I don't know, I look out for early signs of things, and it can be as easy as, skin changes on the legs. It can be as easy as kind of those numb and tingling feelings in like the hands or feet. It can be, waking up, with headaches, or like you didn't sleep well. And that can all be kind of signs of relatively easy to fix things that can have long-term effects, and fixing them early can kind of prevent a lot of these other issues that we really don't want to have to deal with down the road. I would encourage other gainers to, not avoid the doctor if they can. I mean, I would encourage them to get early checkups. And if something comes up, now you've got time to shop around, because it may take a year or two before you find the physician that you're comfortable discussing things with and like actually making some progress. especially if you're moving or if you're between jobs or if insurance is going to change. Like, it can all be difficult to navigate. But waiting until your high blood pressure or your diabetes or whatever has gotten to such an extreme extent that now the solutions are also seemingly radical is not going to set anybody up for a comfortable conversation.
Right. Just curiously here, because I know you mentioned that we talked about this before, like the medical information doesn't travel from doctor to doctor. When changing doctor, like if you were moving, is it easy enough to go to your local GP or doctor and say, hi, can I please have either an email version or I have a thumb drive? Can you download my medical log on the thing and then I can take that with me?
So I have worked so before medical school, I worked as a clerk in a physician's office. And so a lot of like those medical like records requests and things are made more difficult because it is all on paper. Like the systems just don't communicate well. There was legislation in place to make a common speech for all of the electronic medical record systems. That way, if you had to move from one physician to another, you could have your record downloaded in a common format that could be uploaded into the new record system. But it continuously got pushed back. And so I'm not entirely sure where that ever ended up. I think it's buried deep within a lot of the EMRs now. And a lot of that legislation got blocked by the big health conglomerates, which have attached to one EMR. It's all very political in the States.
Oh, yeah. It's ridiculous.
So, yeah, one of the major things is like there just honestly isn't enough office staff to print off all of your records so that you can move to another physician. And there's not a lot of investment. There's not a lot of incentive for me as a physician to pay extra staff to take care of the clinical duties of printing off records so that you can leave my office and go see somebody else.
Right. Because at the end of the day, in America, it's not public healthcare, it's
privatized,
yeah. Okay.
I was going to say that, like, when I had mentioned the Cleveland Clinic, like, they have this system called MyChart, which is like, it'll compile everything that office has done for you while, you've been under their care. And so I suppose the expectation is then on the individual to compile that data themselves and present it to the next doctor, like that's probably what they expect of us.
Some stuff is changing, and there's new legislation coming through about how primary physicians communicate with other physicians and how they communicate with hospital systems. And a lot of how reimbursement is just changing from the ground up, and it's going to be with the community physicians first, because they're going to start paying you for how well you take care of patients, but how well you take care of patients is very much going to be based on how patients respond to whatever treatment they're paying for. So I go to the physician, they tell me I have prediabetes, they prescribe me metformin, I tell the doctor I don't like metformin, it gives me stomachache, it's documented incorrectly, my blood sugar doesn't improve, they're not getting paid because there was no value to the care that was provided.
Which is precisely how it should be.
To some extent, it's not the physician's fault that I know
that, but like, you know what I mean? It's like if services rendered didn't improve the problem, why should you then be charged for the service?
I agree. Compliance is what kind of like comes between all of it. And compliance can have lots of reasons. It can be financial issues because you never got the medicine, or it can be because I didn't tolerate the medicine. But where that can be communicated effectively, I think, within different healthcare providers and in notes, it doesn't translate into code, which is all the billing people care about.
Yeah.
Gotcha.
So, trying to make math out of art is difficult.
Very true.
I really appreciate this conversation. I just think it's so fascinating to kind of learn really the back end of medicine and, the personal experiences of someone like yourself who is not only plus size, but is a gainer and is a medical professional and has worked in bariatrics and has, some knowledge of how all this kind of goes together. And it really just seems to me like the overall answer is doctors are not gods. Doctors are people who are trying to do their best. So patients who are listening should give a bit more grace to their doctors. And also, I think for those of us who live outside of the US, we should be very, very grateful, because here in the UK, a lot of people who live in London live in these fabulously refurbished apartments that are like former child workhouses. And the reason why we no longer have child labor is because people petitioned fucking hard to not have child labor laws. We petitioned to have weekends. That's why we have them. We petitioned to have fair pay, which, that's not exactly happening these days with inflation and whatnot, but that's beside the point. I think a lot of people, like myself historically, would listen to stories about the American healthcare system and go, God, what idiots, they can't figure it out. But actually, if it weren't for our labour unions, I'm pretty sure our medical situation would be just the same as yours. So, for people listening, let's be a bit more grateful for what we have. And if you live in a country like the UK or Australia, and I think Canada and New Zealand are like this as well, go to your universal healthcare systems, put yourself in it, get regular checkups, because at least you don't have to pay for the most part. You can just have access to healthcare that Americans don't. So there's no reason why you shouldn't, I guess. But this has honestly been a fabulous conversation, Dr. Gaynor. Thank you so freaking much for this. This has been a true blast.
No, happy to help and answer whatever I can from, like I said, my unique perspective.
I think that's it for now. So thank you so much for being here. Thank you so much for giving your time and your experiences. Where can listeners find you online?
I am on Instagram as A16851, and I'm on Grommr as A_16851.
Fantastic. Well, listen, that's been another week here on Thicc Radio. Please remember to like and subscribe, rate us 5 stars, and leave us a good review. If you like this episode, the podcast, or just us in general, share it with your friends and encourage them to tune in. You can find me on Instagram, BeefyFrat, and Stuffin' Show at stannnum.
And you can find me on Instagram, Twitter, YouTube, TikTok, and BeefyFrat at ThiccyMouse. You can also look us up on Instagram and TikTok at Thicc Radio, or at our website at www.podpage.com/Thicc Radio. If you want to submit a voice note, you can find the link in the show notes. And if you have any questions or ideas for episodes, you can reach us at thethiccradio@gmail.com. So until next time, bye, Fats.
Bye, Fats.
Bye, Fats.
Let's talk about it.
Thicc Radio is a Patreon and Anchor app podcast produced by Stan and Thicky Mouse.
Mixed and mastered by stannnum.
Our artwork is provided by Lokitu.
Our theme song is provided by Spotify.